took that challenge on and visited about 15 different clinics, came up with a management program for hospitals and clinics. It's embodied in a 110-page standard operating procedure manual with many forms and desk guides and reports. And in the background, an HCE IT system with a data warehouse that's storing all this data and issuing management reports on Tableau on a weekly and monthly basis, which the people of the district can download and print out. So this is really a modern management system in a third world setting. We provide an equipment package with diagnostic devices, things like blood pressure kits and stethoscopes and thermometers, scales for weighing, hand washing stations, computers and printers, very basic equipment. We install a patient record system with patient treatment forms, which they have not had, maternity forms, so the patient can actually leave with a piece of paper that summarizes all of the treatments they receive, the medications, the diagnosis, and so forth, the lab test results. We have clinical procedures we train the local staffs in and how to take vital signs. We have programs for tracking unfilled prescriptions because stockouts of medicines is a big problem in Uganda. The facilities all have pharmacies, but they run out of stock, and about 30% of all prescriptions are not filled. So we've got management programs to try and correct that. We're also measuring clinician productivity because some of the doctors have jobs on the side and don't and have absenteeism problems. So we are actually tracking attendance and tracking patients treated. We have a whole system of weekly dashboard management reports that are measuring key performance indicators. And our program also involves cultural change using whiteboards and visual management. Next, please. However, medical camps are not possible in a pandemic environment. The last thing you want to do is get 17,000 patients together on one place, waiting shoulder to shoulder for their health care. When the onset happened in March, all Uganda medical camps were canceled for obvious reasons, and we found ourselves without a program. So we came up with a new approach. Instead of the patients coming to us, we decided we will go to them. So we created something we call the clinical support team, and we used as a target district, Wakiso district, which is the largest district in Uganda, serving a population of 2 million people. It surrounds the capital of Kampala on 3 sides. So it's really the suburban area for Kampala. And they treat 620,000 patients a year. So much larger than Sheema District, more than 3 times larger. And so our clinical support team program creates teams of 7 clinicians each. We assign them to 2 facilities in neighboring areas, in this case in the Wakiso district, for 2 months at a time. We organize the year into 4-week cycles. So between June, when we started, and December, when we're finishing for this year, there were 5 4-week cycles. So we have 4 teams each in each cycle. So there's a total of 20 teams, each treating 2 facilities. So altogether 40 government facilities that we are where we are treating patients. And we're providing the same services that we provided for our medical camps, except we've added COVID training and PPE equipment. And we're now supplying medicines and supplies at these local health centers. And we're also providing emergency transportation and management reports that they haven't had before. So there's a cultural impact. When we have our 7 volunteers showing what they do, they demonstrate a highly productive, professional, and enthusiastic attitude. That is what you have to do to treat patients at a medical camp with that kind of volume of patients. And we've gotten letters and appreciation, expressions of appreciation from the in-charges, the general managers of these government facilities, because they love the fact that our teams are modeling a kind of energetic behavior and positive attitude that's hard to instill among career government employees. So we've had a beneficial impact just through osmosis by being there. The other thing is that we are providing ambulance services. It happens that Wakiso doesn't have any budget for ambulances. So there are 20 to 25,000 20 to 25 emergency cases every week where we are paying $25, calling the ambulance and having them taken to the nearest facility that can treat whatever ailment they have. To give you an example of how simple this can be, our second day at the Wakiso Health Center, they came up to us and said, can we borrow your car because this mother has an obstructed uterus and needs a C-section, so we have to take her into Kampala, which is a 45-minute to an hour drive. And we said, why do you have to take her there? You have an operating room here. And they said, oh, but we're all out of sutures and we don't have a budget to replace them. So we said, well, we've got sutures. We brought sutures with us. That's part of our supply kit. So we immediately performed the C-section, but that just gives you an example how in this kind of a setting, sometimes the lack of sutures keeps the surgeons from doing surgeries and creating emergency cases that could have resulted in catastrophic consequences for mother or baby. So we now expect to treat 60,000 patients this year for a cost of, again, between $5 and $6 with a totally new program that just started on June 8th. So we're very excited about this, and the reception has been fantastic, actually. Next. Now, our second pandemic response program is what we call a surgery intensive. The poor people of Uganda, the rural subsistence farmers, do not have health insurance. So when they go to a hospital for surgery, they're told you have to pay for cash or we can't treat you. So even though the walk-in clinics are treated for free, if it's surgery, it's another matter. So we have set up, in addition to the surgeries we're doing in connection with the CST programs, which are really outpatient surgeries with local anesthetics, we have set up a monthly surgery intensive program to handle the more serious inpatient cases requiring overnight care with OR teams, anesthesia, and proper instruments and supplies. The district schedules these cases for the last 4 to 5 days of each month that we're there, and then we bring in our own team of highly qualified surgeons and support staff and provide the necessary equipment and supplies. You can see here in the first 3 months, our first 3 surgery intensives were growing in popularity as word got around. So if you look at the total at the far right, over the 3 surgery intensives, we treated 384 more serious cases and for a cost of $36,000. So the out-of-pocket cost for us was $94 per surgery. So again, imagine in a US hospital, $94 couldn't pay for parking for your surgery experience. It's an amazing phenomenon, and this is a phenomenon in Africa too. People can't believe that we treat patients for $5 or $6 each, or that we do surgeries for $94 each. The resources are there. Again, we are the catalyst organizing them, but it's really the skills and goodwill of the Ugandan people that allows us to do this. Next slide, please. The third element of our pandemic response program, we call the HCE1 program. And what this is a modified version of our Health Center Excellence program. So after the 2-month clinical support team program ends, we install what we call HCE1, which is a phase 1 modified program of the full hospital management system. And at this point, we shift into a train the trainer mode. The CST teams are no longer on site treating patients. And so we now have our own full-time staff, 2 or 3 of those people who go out and train them on our new procedures. And then we also extend our disciplines. Remember, the CST are treating 4 health centers with 2 teams at a time, but some of the districts have 10, 15, 20, or 25 additional health centers. So we now extend those disciplines to all the HC3, the HC4s and HC3s, as they call them, in the district. These are all the community hospitals and maternity hospitals. So we're extending our reach, but we also still provide the PPE equipment and training, the vital signs equipment, the patient forms, the clinical procedures, the ambulance services, and the basic management reports. Then after 6 to 9 months of the HCE1 program, we plan to roll it into the standard HCE2 program that I described earlier. And in that case, we're actually tracking attendance, we're measuring productivity of clinicians, and we have a full suite of management reports, and we extend it to the HC2s, the health center 2s, which are village level walk-in clinics that are staffed by nurses. So we now have our disciplines applied at hospitals and clinics throughout the district. So the HCE program is a way of shifting the emphasis from primary care, where we're providing the treatment to the poor people of rural Uganda, to a system strengthening program that is changing the way healthcare is provided at the Ministry of Health facilities, of which again there are 3,200. So by the end of 2021, we plan to have our partnerships in place with 14 different districts, or 10% of the total districts in the country, using some form of our HCE hospital or clinic management procedures. So this is sort of a backdoor way of getting into the Ministry of Health and making our process and procedures indispensable to them. And now we're at our final slide. So in conclusion, Bulamu is really uniquely positioned to reform the Ugandan healthcare system from within. When I met with the permanent secretary, equivalent to our Secretary of Health and Human Services, Dr. Diana Twine, and described the HCE program we were installing at Sheema District, she said, "How quickly can you extend this to all 3,200 Ministry of Health facilities?" And earlier in the conversation, she was saying, you know, we don't even take vital signs, and which has been the standard of care in Western medicine since about 1970. And of course, what I'm thinking is, well, if you're in charge of these facilities, and if you can't make them take vital signs, I mean, I wonder why not. So you can see that the challenges you face in a developing country are just very different than what we see in what we're used to in the West. So what is our sustainability strategy? Well, what we're now doing is using our CST partnerships, which is primary care, to win the trust and credibility, roll into the HC1 simplified version, and then HCE2 complete version of our hospital and clinic management system, and win the support of each of the districts one by one. And ultimately, we think that when we've got this going in enough districts, the Ministry of Health is going to say, we need to continue this. Now, they do have their own budget. Much of their budget comes from outside support from international organizations and the USAID in the US. But we believe that if the MOH says, you know, there's this program we want to start funding, so we'd like to earmark some of your $80 million or $100 million or whatever it is to these programs, we think they have the clout to make that happen if they decide that once we've shown how it works, that they want to adopt this as their own standard of care. So that's really our longer term program. And if we can add 10 new districts a year, it won't be very many years before we've got a majority of their districts using our programs. And I think we're going to get, they're watching what we do. And I know we're going to have a lot of impact as we move forward. So for us, and for me as CEO, the biggest challenge is building a US donor base. Imagine what we could do if we were like Mercy Ships. But we have to find foundations, not just individuals, but foundations who believe in our program and will fund our tremendous growth opportunities, because the demand is really unlimited. And there is no NGO providing healthcare in Africa that can match the cost of effectiveness of our programs. So my challenge is to extend our network of supporters. I posted there our website, and we appreciate any help you can give in for opening doors for us to people to whom we could tell this very story that you've now seen, and see if we could enlist them. Because it's all about foundations and major donors at this point. So again, just summarizing, Bulamu very simply is a Ugandan NGO helping Ugandans help themselves with innovative health delivery programs that are relying on American donors. So thank you very much for your help, and we're now, or for your attention, and we're now open for questions.
Thank you so much, Dick. We are going to start taking questions. As I said earlier, please write your questions in the chat window for Dr. May, and we can moderate them. But I would like to turn over the mic to Dr. Mayo and if you want to provide some moderating remarks, and then we can do some Q&A. Dr. Mayo, you can go ahead if you want to give any closing remarks.
Start with a comment, Dick, from Bruce Mongalgli, a colleague of ours here who runs the entrepreneurship program within the College of Social Sciences. He's just saying I've lost the text somehow, but if I remember, he says he just wanted to congratulate you on an incredibly adaptive program, one that doesn't do what so many NGOs do, which is come in with a solution before they really understand the problem. It sounds like beginning with Jim and his partner, they really understood what the dynamics were and what the obstacles were, and started with the problem instead of a solution.
Yeah, exactly. And actually, Gerald said to Jim, because he was a night shift nurse, and they had 5 or 6 nights where they were talking. Jim was the guy that liked to stay up late and talk. You remember that from Princeton, John. And so Gerald said, well, if you raise the money, I'll run the camps, because I've been volunteering at some of these camps and none of them are done right. And having worked at Yale University Hospital and in the Kaiser system in California, he knew how proper healthcare services should operate. So it was really an ideal partnership for getting this off the ground.
This is from Marianne Fugit. Is COVID-19 interfering? Hold on, I just lost the question. Another question popped up right in the middle of Marianne's. How can I get back to Marianne's?
You'll probably be able to scroll back up.
Marianne, would you come back with your question? Can't seem to get it. Okay, Tom Taylor's question appeared and disappeared too. Okay, is COVID-19 interfering with your ability to perform surgeries in Africa? And are you able to sterilize equipment and protect patients effectively?
Well, the people on our staff know what it means to sterilize facilities. We wipe down everything. We bring our own autoclaves to make sure that the instruments are sterilized. Everybody's screening. We provide infrared thermometers, so nobody has a temperature unless it's some kind of an emergency. So yeah, we're taking all the same precautions you would take in the US, and we supply the PPE that you would use in the US. So what we did find though was medical camps don't work. So by us going to them, we were able to use the same skills that we have for our camps. And by the way, I saw a lecture by somebody that does a lot of support of NGO, who was giving a seminar, and he said, in a pandemic environment, and most of the leadership are not very good, because operating within a model that they're used to, they've never had to think resourcefully. But if you have in a need of change, but if you've operated in a business environment, you're having to change all the time. There's all kinds of examples where yesterday's product is no longer even being used today. So, how many of you still have iPods for your music collections? But that was a huge hit product 15 years ago. So I think in business, you learn that, and that's what I learned. And I think that's where my perspective as a CEO and a business guy was useful in saying, okay, we've got a lockdown for 3 months, but in June, our people can travel. They loosened it. Our people can now travel. What can we do that isn't a medical camp, but uses the resources we do have? And we found that we sent a draft MOU, a memorandum of understanding, to the leadership in Wakiso, saying, if we provide these services, will you sign us up? And the chief administrative officer sent it back the next day and signed it and said, when will you start? So we sent it to him on June 3rd and we started on June 8th. I mean, that's how anxious they were to have us come. So it just happened that our resources were very valuable, but in a totally different context. So I think that's the combination of Uganda flexibility, but also the discipline of business that sometimes I think NGOs just aren't used to, how you have to do that frequently. I mean, look at what companies are doing today in a pandemic environment. They're being resourceful all the time in different ways.
Dick, we have a question. How do you analyze the existing situation to come about with these innovations? How did that happen?
Well, again, it's what you do in business all the time. You go out and talk to customers. So I visited 15 health centers and I found out what's not working. And the one problem we can't solve is that the drug distribution system is so inefficient. The US drug distributors turn their inventory over 13 times a year and they deliver next day. So if you run out of sutures, you place an order by 5 p.m. and it'll be on your dock, your receiving dock the next morning by 10 a.m. So we're used to next day service in healthcare in the US. The Uganda system delivers once every 2 months. So the government controlled system makes you decide 2 months in advance what you need, which is incredibly inflexible. And interesting, you might say, well, that's the difference between Africa and the US. But there is a private distributor in Uganda that has 4 regional warehouses. And again, imagine 4 warehouses in the country the size of Oregon, and they deliver next day. So there's nothing about Uganda that keeps you from having a system like Cardinal or McKesson or Amerisource has in the US. It's just the government is too rigid to do that. So we're trying to reform that. But it just shows that any of these systems work in Africa with the right kind of leadership.
Okay. I now have the full question from Bruce Montiagle, who I mentioned previously. He says, this is a great example of a holistic social impact model that addresses an adaptive problem systemically. You shared how the Ministry of Health is enthusiastic about scaling the model throughout the ministry and health centers. Has culture change met with similar level of enthusiasm from the layers of clinical staff?
It's mixed because doctors don't really want to have their productivity measured. Some of them have practices on the side and only show up 2 or 3 days a week, but they're salaried and there isn't a tough enforcement system, although it's getting tougher. But in general, it's just mixed. Compliance, you start out and might bat 500 and then one by one try and bring in everybody into the fold. So it's not, it's the compliance and is not what you would get in a Western country. But I think we do make steady progress, and you start with the people that love what you're doing and then work your way through to the rest. But the compliance is a big challenge. And even in the ministry's health's own systems, they rank all 135 divisions on responsiveness to their programs. And they find that in some of these programs, they're getting 50, 60, 40 to 60% compliance, and then others 80, 90 to 100%. So it's a fact of life there, and is an ongoing challenge.
Okay. Here's a question from Elizabeth. I know that the U.S. does provide international aid for mothers to deliver their babies. So does your NGO receive any reimbursements from the U.S. government for mothers' care?
We do not. We've talked to the USAID mission, and they sort of said, look, you don't want to have a contract with us. It's a long process. You need a staff of 3 or 4 people just to submit the application. And there's all kinds of controls. And so it used to be there were programs for small NGOs through USAID, but right now everything goes through implementing partners. So there's about 5 organizations like Partners in Health that have feet on the ground. They've got teams of people, 250 employees, and a fleet of 100 Toyotas that will go out and spend, visit these health centers, and they'll come in and spend 45 minutes and then leave. And that's how things get implemented through those partners that have multi-year, multi-million-dollar contracts. So we ended up realizing, and actually the head of mission said, you don't want to go down that road with us. You're not ready for us. Imagine we have 1 full-time employee in the US. Who would we have that would be submitting that kind of a contract proposal? So we're sort of doing it our own way and working directly with the Uganda government and local NGOs. And, we'll see how it goes. But I do think that USAID budget is influenced by what the Ministry of Health says we want this year. Mm-hmm. And so I think that there's a point at which we could access those funds through Uganda, which is our strategy.
Another questioner asks, or she says, when I was in Uganda, mothers will travel 10 kilometers to get vaccinations. My question is, are there transportation options for people to get medical services if they are not able to get to the campus? And also, where is the campus?
Well, there's 3,200 campuses, and everything we do is working through a government facility, as I indicated, and we'll be at 40 this year with our people or trained people after us. What they do is they walk along. The average Ugandan, probably 95% live within 3 kilometers of a health center. Most of them are health center twos. These 85% of healthcare in East Africa is provided by nurses. And those are these village walk-in clinics that pretty much everybody can walk to one. But they also use boda, motorcycles. In every village, there's 10 or 15, usually young men with motorcycles waiting to take you wherever you want to go. But if you're an emergency case and need a vehicle, that's another story. So they do manage to come to us. And of course, the bus system works, but they're used to waiting online. Everything involves queues and everything is unreliable. So the 10 a.m. bus leaves at 11:30 or 12. So that's the environment they're used to.
Okay. When patients are referred to more specialty hospitals, are you able to negotiate prices without the leverage of reimbursement through insurance like we have here?
Yes, they're used to working without insurance. For example, Cure and Corsu, two of the hospitals we use that are funded by Western donations, they cover about 90% of the cost of surgery. To have these surgeons, these are very specialized facilities and they're wonderful campuses and they look like hospitals in the US. So what we do is we pay for the patient's part of it and we pay for transportation and upkeep meaning your local housing and food expense while you're there for 5 or 6 days waiting for your child to have their burn, their burn surgery completed or whatever. So we pay whatever the patient needs to have it done. And the hospital bills us directly. We have an MOU with those hospitals. So we sort of smooth the path for them.
Okay.
Yeah.
Another
we get the same pricing, we do get the same pricing that insurance companies would have. There are some insurance companies, but very few. Go ahead.
A big obstacle this questioner saw when in Kampala, Lira, was reliable or ability to pay for electricity to keep vaccines and other medicines cold.
Well, the districts all have where the drugs are, refrigerated drugs are stored at a district storeroom of the 135 districts, and they have generators. But power is out a lot. I mean, I was making this very presentation, a version of this at a new district, and there was no power that day. I'd brought 6 hard copies, but there was 18 people in the room, so that wasn't great. So I basically just talked them through it, but it loses a lot of impact without the slides. So that is a fact of life. They do have, if you leave meds in a freezer or refrigerator, they will stay cold. It tends not to go out for days and days, but very frequently for hours at a time. So that is part of that environment. The health system does function. Let me just say, if you were in Uganda 20 years ago or 30 years ago, it would be a different place today. And I find in a lot of third world settings, if you ask somebody about what it's like, their reference point is when they went, but that may be quite a while ago. And things are getting much better all the time. When Mercy Ships was started, there weren't doctors in Uganda trained in Western medicine. There was only one medical school. But now there's 11 medical schools and they're all trained in Western medicine. And English is the language they grew up speaking. So it's just a very different environment now than it was, 15 or 20 years ago. And it's for the better.
Tanu, our colleague Bill Clay has a number of questions he'd like to pose directly. Can you unmute, Bill?
Absolutely. I'm going to scroll down and do that.
In the meantime, I'll ask a question from another colleague. Tom Taylor asks, how do you get others to contribute to shared leadership?
Americans love our program, if you mean shared with Uganda, because what sells them is the economics. We're saying, where else can you give $1,000 and know that you're going to treat 20 patients or have surgeries for 10 patients or have ambulance trips for 25 patients, or actually 40 patients, sorry, at $25 each. So it's really the cost effectiveness that is persuasive to our donors. And in fact, I asked a member of parliament, I said, when we treat patients for $5 a patient, does that seem low in Uganda? And she says, absolutely. Are you kidding? I mean, if I just walk in and say, I want to make an appointment with a doctor, it's, you know, it's going to be $15 or $20 just for an appointment before they do anything. And you're treating patients and doing surgeries and all kinds of things, you know, filling cavities and testing for HIV, and you're doing all of that for $5. So that also looks amazingly low. If you convert it to shillings, it looks amazingly low in Uganda as well.
Tano, did you find Bill? Is he?
So hi,
I
look,
did.
great. Let me start off just by saying thank you for a wonderful presentation and congratulating you on the exciting work that you're doing there in Uganda.
Thank you.
A couple of questions, just really following up on this last one, the point that you were making about the cost. The $5 per patient, how in terms of you know, immediate care, in terms of doing surgeries for that, and the $100 and such, do you have an idea what the overall per capita expenditure on healthcare is in Uganda?
It's a good question, and I don't have I don't have that in my head. I mean, it's not very high.
Yeah. So by the time we end up really looking at how this gets spread out and thinking in terms of sustainability and such, it's as excellent as it is. And again, I'm not trying to dismiss it at all. You are doing great work. How to find ways to actually get more money into the overall health system to do what you're doing in terms of therapeutic care, but also then moving into some of the bigger areas, broader areas of preventive medicine and preventive health care. And how do you see the government thinking along those lines of public health activities and interventions compared to what so far your health center program is focusing on with the therapeutics and such? Is there
The people that I have met at all levels of government, I have great respect for. They are well trained for what they're being asked to do. I think their hearts are in the right place. They are challenged by limited resources, but I think they do a lot with what they've got. And NGOs are a very important part of the economy. I think NGOs are, I think I've read somewhere 10% of GDP or something like that. I don't know that number. Maybe some of you do, but so NGOs are highly appreciated and really come up with the solutions that they then try to implement once they're proven. So it's a resource constrained environment.
Yeah.
But what we're doing is showing them how they can do a lot more with their resources through proper management.
Right.
Because a lot of the USAID programs I see, to me, is money wasted. It's a little bit like, you know, sending bottled water from California to our troops in Afghanistan, you know, as if they don't have springs in Afghanistan that are uncontaminated. So, you know, we do a lot of crazy things with global NGOs and American NGOs because we don't think that somehow the local people can do it. And so what we're doing is working with them, and we're finding out that they can do everything we want.
Yeah. Well, part of that, the key to that, I'm really impressed with your focus on this system strengthening aspect of what you're trying to accomplish. One question that comes to mind is in terms of the whole reporting mechanisms that you have. Who prepares these management reports, but more importantly, who reads these management reports and who acts on them? And what sort of decisions can they take on some of these metrics that are coming in?
They have a lot of latitude. They have a lot of latitude because there's not much oversight. They pretty much are operating out there as a lone ranger running their facility. So they don't, not a lot of people tell them what to do. So it's what we do is we have data recorders, like in Sheema, there's 27 facilities and there's 7 of them that we've outfitted with computers, and there are data recorders there, and they collect the information from their little group of health centers, and then enter it directly into our data warehouse system. We have an Indian programming firm that has set this system up. And then the reports can be downloaded on a weekly basis. Tableau is a very common report writing that takes Excel data and packages it in whatever shape you want. So I ended up designing about 30 or 40 different reports. That is what I would want as a manager. So we've given them a turnkey management system because they've never seen reports in their careers. So if I say, what reports would you like to see? You sort of get a blank stare.
Right.
But if I show them something and say, well, if you were operating in the US and I overseed, a chain of 80 home healthcare stores, and I put in a management system for that. And I know what our weekly dashboard looked like. I think we had 36 different metrics that we had to be reported every week by telephone. We had somebody, this is in the 70s and 80s, we had a weekly report that was collected by calling in and reading off 36 numbers, and somebody would write them down and type them up. So you can do this with very simple systems. So I'm using the same approach I would use in an American business setting and have used in my past history. So it just happens that my background meshed perfectly with the challenge that this major donor gave us of, I don't want to try to provide a healthcare system for all the poor people in Uganda, but I would love to fund a system aimed at systemic change, which, and they use the term just as you did, system strengthening, because it's not insulting, everything can be strengthened. And so he challenged me and I came up with it, and it turns out it was very well received. And now we've computerized it, so to speak, we've automated it. And now it's a matter of getting compliance on getting them to submit the data on a timely way. But so we're working with the constraints of the environment, but it's working.
Yeah. But who's reading these reports and acting on them? It's still
well,
not
the
clear.
27 facilities. The 27 facilities have 27.
The individual
in charge
facility is the ultimate user of the reports that are being compiled
Yes,
at this point.
there is a district health officer to whom those facilities report. But if you had 27 restaurants in the US, you'd have 4 or 5 district managers, each of whom supervised 4 or 5 restaurants themselves and was once upon a time a very good restaurant manager and learned how to do it. In the US, all 27 facilities, in Uganda, all 27 facilities report to the district health officer, who is torn in about 100 different directions.
Yes.
So really, the managers of these facilities and they're doctors or nurses, they're clinically trained. They're the ones that are operating, and they're the ones we have to work through. But they like seeing the reports. They've never seen reports before. And we show them a weekly dashboard and they're like, wow, this is amazing.
Yeah, it's good.
Well, thank you, Bill.
Compliments
That's
again.
the extent of the questions submitted to me. Tanu, do you have any additional ones, or are they?
I do actually. We do have 2 more questions. One is a rather straightforward one. And this question is, how does the news for super camps spread? Because every 3 kilometers, there are these individual clinics, but people are traveling longer distances. So how is the news exactly spreading?
I'm excuse me, I gotta close the door. The dog is barking. I missed the gist of that question. Tanu, can you restate it, please?
The question is, how does the news for each of these super camps spread? Because people are traveling such long distances. How do they hear about them?
Oh, that's amazing to me, because people are coming, like, people like with these goiters they'd had to live with. What happens is somebody calls them, it's an aunt or an uncle or a cousin or a friend, and says, these people, Bulamu, are coming to town and they're doing free surgeries. So there's a lot of word of mouth that is very surprising to me how it works, but it works very effectively. In fact, we just went to a new district with our clinical support team program. And the very first week we were there, the patient volume doubled. And these are districts we haven't been to before. And I'm thinking, how did they know? But somehow Bulamu has developed a brand where they know that they're going to get treated, it's going to be free, they're going to get the meds they need, it's going to be professional clinicians. And so we're finding that our budgets are low because everywhere we go, the crowds are bigger than we expect, which is good news for everybody but me, because I'm in charge of fundraising. And that's where I've got to find more money.
Do you ever use radio?
The local district does. In fact, the local district has loudspeakers. I guess if you want to know specifically about media, yeah, there are local radio stations. And I was interviewed on one, for example, but the district people get interviewed. And then they put loudspeakers on the top. There are loudspeakers on the top of cars. And when the government wants to get something out, they drive through every village. So Sheema District has 700 villages. And they just drive through them all, announcing, Bulamu Medical Camp comes, at Shuku Health Center Monday at 8 a.m. And by Friday night, people are already camping out on the grounds.
Oh, you are muted.
Dick, can you unmute yourself? I'm not sure what.
Yeah. You got unmuted accidentally. You got muted
There,
accidentally.
that's good.
Okay.
Tano, you had one more question, I think.
I did. And this,
Excuse me, did the answer about the loudspeakers on the cars get heard?
Yeah.
Okay.
yes,
Sorry.
yes. Okay, so this question is, you shared some of the cultural factors that help the super camp model work, like the sense of community, service, patience, trust, etc. To what degree do you believe this model is replicable to other countries in East Africa, as well as other countries in Africa or developing economies in other parts of the world?
Well, that's a great question. And the short answer is, I don't know. We did apply to the Gates Foundation and said, give us, I forget it was, $100,000, and we'll test this model in a neighboring country like Kenya, Tanzania, South Sudan, Congo. I mean, the latter two would have been more difficult than the former two. And Rwanda is so well organized these days that they don't really need this. It's a smaller country and their clinics function very well. So I'm not really sure, because it's hard to know if you could duplicate the reception we get at the government, if you could assemble the volunteers. I think that what I found in business is that you adapt your model to different countries. I mean, Walmart is different in Brazil or India than it is in the US, but that I think business teaches you how to adapt your model to the local environment. So I think there's an answer there somewhere, but I think the specifics might be very different. I mean, one thing about Uganda is it doesn't need more bricks and mortar. In fact, because again, there's 3,200 facilities. So I actually visited a walk-in clinic that was funded by a couple in Tulsa, a doctor and his wife. And there were 3 very nice buildings, but there was a nurse there when we were there, and she treated 8 patients in the morning, and that was it. And I asked, why aren't more people here? Somebody put a lot of money into this. And they said, well, they never collected the electricity. So you've got a healthcare facility with no electricity. And I'm not sure there's running water. So if that's the case, this poor couple from Tulsa thought they were doing great things, and nobody told them that, by the way, you really need water and electricity to have a health center. Yeah. So I think you see those kinds of things and sort of wonder, well, what were they thinking? But that
Dick,
doesn't happen with our organization. We're using Ugandans who tell us what's needed, and we listen.
Dick, here's a question. Is your NGO or the government usually a provider for people who have diseases or conditions that require medication for chronic diseases?
That's a great question. When you supply blood pressure kits, you realize that a lot of people have hypertension and they need ongoing meds, like I've been on for a number of years, very common. And so the answer is yes, they do have a program, just like they've adapted to HIV. By the way, the HIV program through PEPFAR, George W. Bush's program, and through the Clinton initiative, are very effective there. and you have, they call it an ART clinic, and everybody comes in once a month to get their meds and to get counseling and whatever else they need to have their test taken. So that's an example of a sort of an internal ecosystem within the Ministry of Health network. It's just at the HC4s, not everywhere. So they have to travel a little farther. But if if you're dependent upon your meds as an HIV positive, you'll do that. So that's an example of a program that's long-term maintenance, doing very, very well. So I think the government is capable of doing that. And I think they're doing that with hypertension drugs too. So I think they can adapt to that, but it's still a very imperfect process. But again, I guess I would bet if you took a snapshot 10 years or 20 years ago, you'd end up saying they've made tremendous progress.
Last question. Person seems to be aware of a successful system of village health teams in Uganda. Does Bulamu liaise with them?
Absolutely. Every district has 1 or 2 VHT members in every village. So Sheema actually had 1,200 VHTs. And one of the doctors that advised us said, these medical camps are great, but healthcare is not a one-shot deal. Healthcare is take this medication and call me in 2 weeks and tell me how you're doing. So you really need some continuing care to be effective. So we took that to heart. And so we went to the district after our medical camps and said, we have a follow-up form that basically says, how are you feeling? Was it successful? And if you need ongoing care, here's a referral form, a piece of paper that we will give you that you can take to your local facility, which gives them sort of a ticket to get in. Not that they need one, but that's very important. Here's a ticket that says I was referred to you by another clinician that says I need you to help me. So we trained 120 VHT members to go out and do those interviews. And they interviewed everybody who they could find. Who we couldn't interview them if they came from outside the district. And we've done that now for all of the last, I think, 12 medical camps. We use the VHTs for follow-up, but they're not paid. They're volunteers. Now we pay them 1,000 shillings or about 27 cents per interview, which they love. And some of them did 100 interviews. So that turned out to be real money in their views. So they are a resource. They don't earn a salary, but they get a very nice shirt with a logo. It says VHT, and they have been trained and they can administer medications. So, and be an adjunct to the local health center too, that's run by a nurse. Yeah. So we are aware of that program, and we've used them as a resource in about 12 districts. Okay. Now that we're not doing medical camps, we're trying to decide, should we use them for follow-up in our CST program? But in those cases, the patients are generally pretty close to their district, pretty close to the health center. So it's not as big a problem.
Well, thanks to the excellent questions, we've gone well beyond our scheduled time. And I want to thank all the questioners, and especially you, Dick, for this incredibly comprehensive and informative and inspiring afternoon presentation. It was really remarkable. And for those of you who are still with us, Dick has agreed to share the PowerPoint with anyone who would like to look at it a little more deeply and perhaps drop him another question or two. I'm sure he wouldn't mind. So if you could send either Tanu or me your request, I will forward it to Dick, and we'll go from there.
I mean, you guys have a copy of it. If they just want a copy of the slide deck, just you're welcome to supply it.
Right. Okay. Great.
And then I'll be, if you have more questions, I'll be
good.
I'll be available. Thank you very much. You've been an attentive group. I'm sorry for the rough start. I had some kind of a firewall set up. All of a sudden, I couldn't get to Zoom. It's like I tried too many times. So I don't know what happened, but anyway, I have to look into that, because it's obviously it's the stock and trade. My teaching was done through university systems that now that I'm not teaching because I'm an adjunct, I tried to log on and that didn't work this time. So anyway, sorry for that, but we got through it. So using my daughter's computer.
We surmounted it. Thanks again.
Okay.
Well, thanks again for everyone from attending. Do you have any news, Tanu, about the next program or what?
Please watch out for more news from me. We are planning for one on the week of November 16th, which is the International Education Month, and will address the social justice theme for Engage Your World. But I will contact all of you with a feedback survey, And I again want to thank Dick for joining us and Dr. Mayo for coordinating and moderating the session. And thank you for being a captive audience. I really
Okay.
appreciate it. And have a good evening, everyone.
Okay, goodbye, everybody.
Goodbye.